We're going to go ahead and get started. Appreciate you guys being here. The intent is to focus this particular didactic on imaging a patient with a heart pump. We'll focus on echo, and Suming will focus on, I'll focus on echo, Suming will focus on CT. I think it's important to keep in mind, just a few slides in background, why we're using these pumps and where imaging comes into play. And the aim is just to create remission of clinical heart failure as from a hemodynamic perspective in terms of unloading the LV and improving flow. And it's what's unique about these continuous flow pumps is that we can dial in the speed where we're achieving our primary aim of heart failure remission, but not at the expense of over-unloading or partial LV unloading. Over-unloading can lead to suction events. Partial LV unloading, you don't get the benefit you wanted as it relates to smoldering heart failure. And so it is key. And these devices now, certainly with destination therapy, there are about 150 centers across the country. We're doing more pumps than we are heart transplants. That transition happened over the last few years. So that equates to about 3,000 LVADs per year, anticipated to be coming up at about 4,000. At our center, for the last few years, last year we ended up doing 55, previous year around 60. So it's certainly a end organ intervention for heart failure that continues to gain some ground, and I think you'll continue to see it more and more. Just to focus in on some of the basics, there are 2 approved LVADs. The HeartMate 2, as demonstrated here, is our workhorse. It's approved for bridge to transplant and as destination therapy. That means patients have a contraindication to transplant, and we use the pump from there on out for therapy. The Inflow cannula is in the left ventricle. The pump itself with the HeartMate 2 subdiaphragmatic, and the outflow cannula in the graft is anastomosed to the ascending aorta, and it courses the right peristernal along. And I think that's key in terms of outflow cannula interrogation. The other pump that's approved, and I would say 90-95% of all our pumps are the HeartMate 2. You may see in the Echo Lab the HeartWare. It's really an HVAD in the company's HeartWare. Now this device is different in that it's centrifugal. The pump is actually just adjacent to the apex, so it's pericardial. The idea is the pump's going to be really close to the heart, so it's not subdiaphragmatic. But the outflow cannula, the outflow cannula graft, the interrogation, the anatomy is the same. And they're continuous flow. The HeartMate 2, the pump comes in and it comes into the pump on axis and leaves parallel to the direction of flow. Centrifugal just means the blood flow comes into the pump and leaves at a right axis. And so they're both continuous flow pumps. They're both very robust pumps in terms of LV unloading. The pump that we have a lot of enthusiasm about, which is currently undergoing trials, and we've enrolled 13 into the study, several on the HeartMate 3. It's more like the HVAD in that it's adjacent to the apex. It's not subdiaphragmatic like the HeartMate 2. So but it is, and it's centrifugal like the HVAD. So it's a smaller pump. Its design is very unique in terms of this magnetic levitation. So there's no bearing. We think the longevity is going to be good. And what's really unique about it is the pump will auto-adjust its speed in increments of 2 seconds. So the speed will drop and then come up. So you get washing out of the pump. We call it an artificial pulse. We don't understand the implication of the aortic valve, but the hope is that we curb adverse events associated with this pump, namely pump thrombosis, with this device. And so it's an ongoing trial. It will be completed in August. It will be a landmark trial for us in the field, over 1,000 patients. So how I wanted to organize this talk, perhaps different from last year, is really clinically based and focused in on our protocols and templates and expectations. And there are 4 reasons why we'll order an echo. It's as a surveillance protocol. We tend to get it in and around the time of discharge at 1 month, and then every 3 months out to a year on average. And we're monitoring how that particular patient is doing at that particular pump speed. Things can change. Patients can develop a clinical heart failure. So we look at the baseline echo, and I'll go over the specifics. But we're looking at LV size, mitral valve regurg severity, any complications related to aortic valve, persistent closure, and possibly early fusion and/or aortic regurgitation. So surveillance studies are our mainstay. The second study we get, and these are in order of frequency we order them, is a optimization study. And we're doing this if there is a change in clinical status or per protocol at the time of discharge, at least once. And we change the pump speed and see how the heart looks to ensure that we're doing our best with pump speed with the idea that we can perhaps maintain some aortic valve opening but still create this heart failure remission. The third reason we would order an LVAD is to screen for pump function. Sometimes there's smoldering hemolysis and there's thrombus in the inlet of that rotor. And if we have significant hemolysis associated with pump malfunction determined by echo, we'll exchange the pump. If it's hemolysis with normal pump function, we'll try to treat through in the context of more aggressive anticoagulation. And then the less frequent reason would be to screen for recovery. And to be honest with you, recovery in terms of the heart getting better, where we can take the heart pump out and where the patient is expected to do well, is a low frequency phenomena. I would, based on registry data, probably about 1-2%. The real role for recovery, we call it recovery, but even patients that don't have demonstrable improvement in their LV, they have an LVAD complication, and we want to know, well, can we take the pump out? And is it safe? So weighing that benefit risk assessment. Now, what's nice over the past several months in how we order it, this is all in method. And so we will order the appropriate study, and so the techs will hopefully acquire the specifics related to the questions being asked. And what we're doing a better job of is putting in what type of heart pump they have. Is now we have 3. Is this a HeartMate 2? And its pump speed range is different. Is this an HVAD, a centrifugal, its pump speed range is a little bit lower? Or is this an investigational pump, which we're using more often, which I think may become the mainstay? We'll know in fall of this year, and that's the HeartMate 3. So we want to tell the techs, all right, what type of pump was the baseline pump speed? And so this would be key. And now from an acquisition standpoint, just to remind the group, special considerations, for surveillance testing, for screening for pump malfunction, or for optimization, or for recovery, you do a baseline echo. And so you obtain this typical standards views, and everything is standard. Special considerations with regards to the number of cycles, at least 3 to 5, with M-mode interrogation of the aortic valve. And then consideration for off-axis views to look at the inflow cannula. We'll talk a little bit about that. And I like interrogation and reporting on the aortic valve. And we simply, from a qualitative perspective, want to know if it's open after every cardiac cycle, is it intermittent, or is it persistently closed? Really based on that 3 to 5 cycle evaluation. And then the inflow cannula, we're going to be transitioning and moving to more clear, consistent documentation of the inflow cannula velocities. The outflow cannula hasn't been a request historically here with us, unless there was a change in clinical status. Many centers get it routinely in terms of screening for subtle hemolysis. This is just in terms of interpretation. LV size matters. If you were to ask me what echo surrogate do I look at to detect the degree of unloading, it's the LV size. And I'm looking at it and comparing it to the pre-LVAD echo. And we have a manuscript in preparation where we've looked at unloading documented by reduction in wedge. And when we see an LV size that decreases 0.6 centimeters from its baseline, normal wedge. I mean, again, this is just broad concepts. But if I see a pre-LVAD echo 7.2 and they're a month out, New York Heart Class 3, they have background COPD, and their heart size is 6.8, that's most likely partial LV unloading. And I'm going to look at the degree of mitral valve severity, whether the aortic valve is open or not, and importantly, the clinical picture. But LV size is key for us, and it becomes very important when we're changing the pump speed for the other reasons why we're ordering the echo to begin with. So we focus a lot on the basics of LV size.
Can we have your couple of questions?
Yes, please. This is meant to be informal and
2 questions.
yeah.
Stay there and repeat the question. One is
It's no longer informal.
One is the aortic valve. The aortic valve.
Yes.
So usually when I'm looking at this, I perceive a little better the opening of the leaflet on the 2D than on the elbow. It may have to do with the elbow cursor not having
Yeah.
So my eyes do better looking just at 3 or 4 beats in the 2D and seeing that the ellipses are actually moving out and
So-
that's mostly for sonography. I think
Yeah.
when you do an echo, you really need to try to get right to those cusps so you can catch it.
Right, so I think you're right on. I think good 2D, and if it's opening, it's opening. It's easy.
Right.
It's just when you have this unclear partial opening, where they're and whether you're seeing excursion. Yeah.
What is open?
Yeah.
Because the problem is, sometimes we see that the valve is there. It's kind of,
Yeah,
is that
yeah.
opening? Or
So-
you want to see it fully open?
So the truth is, we don't know. I would say opening is where you have a pulse pressure that's palpable by exam. We don't know what degree of aortic valve opening, either in terms of excursion diameter or duration, that equates to a pulse pressure that's meaningful from a physiologic standpoint.
Right, so how
And-
would you like us to?
So this is how I like you to report it. So just like on this M mode, and you can look at the 2D surrogate. If you see aortic valve opening for 3 to 5 cardiac cycles after every cardiac cycles, and I would argue they're probably all partial, if you were to compare aortic valve opening duration compared to a heart failure patient without an LVAD in terms of millisecond duration. But A is aortic valve opening after every cardiac cycle. Now, let's jump to the easier one. Go to C. So if by 2D that valve doesn't look like it's opening at all, and if you have an M mode, and it's at the tip of the aortic valve, right, where you want to interrogate, and you see no demonstrable opening, and it looks like that, you see the movement of the aortic valve, but no opening, that's closed, persistent closure. Anything in between is intermittent. And that's exemplified by some beats closed is in panel B, perhaps very partial opening in the yellow arrow, and more traditional opening, and it's variable. And it can be variable beat to beat. Now, but it has a lot of meaning for us in terms of degree of LV unloading, accuracy of blood pressure, perhaps that particular day we're getting the echo, and some about prognostication in the context of aortic insufficiency likelihoods moving forward. So to answer your question clearly, just like I stated, and I'm going to show you a template that I'd like for us to follow, but hopefully did I answer your question? I hope.
Second question that you just referred, very important, for the LV dimensions that you play so much of.
Yeah,
Some of these patients are not exactly the most beautiful images.
right.
So should we have a policy then of using contrast in any type of situation when the views are not good enough to get that LV dimension?
Yes.
A and B, I
Yes.
guess contrast is safe in these patients, right?
Very safe.
So I think that's important because sometimes these people do have very...
So for the routine surveillance echo, to be honest with you, I'm not looking at EF. These EFs we
No,
looked
but
at.
the dimension-
Yeah, but so dimension I'm looking at. That's the first thing I look at.
Sometimes we struggle because the quality is kind of crap.
So anything so to optimize endocardial visualization to get a good linear dimension, I would love to have that contrast per protocol but much like we would want in a heart failure patient if you can't see and quantitate on size and OB. So I put that as part of the standard. But so yes. Yeah, thank you. Thank you for those two questions. So let's talk a little bit and I'm going to be focusing on those areas that are different. Inflow cannula position. I do think you could get a good hint at this by 2D and Doppler using echo. CT is the gold standard. Remember, we can't do MRI because of the titanium and the LVAD. And so it should be, in terms of what the surgeon's trying to achieve, they're trying to go true apex, and they're trying to point it towards the mitral valve, kind of the left ventricular outflow tract mitral valve, kind of like towards the anterior leaflet of the mitral valve. And as demonstrated below, if it's truly apex in a dilated heart, now the challenge is some of these patients don't have a dilated heart to begin with, or they may have some infiltrated cardiomyopathy or some non-compaction. But the surgeons do it best they can, and we're trying to assess by imaging whether there's no agreed upon universal definition for inflow cannula malposition, but I'm going to provide a working definition in the context of normal reference being towards the mitral valve. And as exemplified here in the middle panel, if it's truly mid-ventricle, on short axis you should see it in the middle. And the color should be at the apex. And I like color because when you can get mirror artifact or artifact related to inflow cannula, so to commit exactly where the inflow cannula actually is, color can tell you nicely. And we want to know the velocities. We use these to understand flow. Some centers are using it to understand potential hemolysis and decrements in flow. And we like reporting, and forgive me, this is not working, but I'll show you clearer. We like to know the peak systolic flow and the peak diastolic flow. We call these continuous flow pumps. Even in the setting of a weak heart, there's still native LV contractility for both. So you get partial pulsatility when you do the Doppler interrogation, inflow and outflow. In an overt situation where the heart's not contracting much, afterload's controlled, and the patient's pump dependent, it will be almost linear. That's very, very rare. 99% you're going to see pulsatile flow relative to LV contribution of flow through the inflow and outflow cannula.
So although it's a continuous flow, yes, there is contraction of the ventricle. Does that increase the flow during that, or are we just looking at velocity going through the cannula?
Velocity going through the cannula.
That's it.
That's it. Wow, that's it.
Does it change the flow at all?
So by flow probe is not demonstrable, and so the flow that's systemic is if the aortic valve's opening and that contribution to what the pump's doing. So yeah, we're looking at, I call it flow, but it's velocity. It's small. I mean, you look at the peak, systolic and diastolic velocities, and we calculate. Yeah, Steve.
So in that bottom figure C, would that not be gross canal position?
So that's a good question, and I would say it's at the apex. Malposition is when it's pointing significantly to the septum or posterior wall, or is at the mid or base compared to the apex. So I would not call malposition on the basis of what I see there. And let's dive into malposition. So we actually look at this in the OR, and by TEE, if they can open up the apex, this is a very nicely positioned pump. And we're looking at the midline ventricle. We want to keep the interventricular septum midline so we don't over-unload. And we're looking at RV, and you can assess this by 2D and 3D, and by Dopplers in the TEE. And I'll skip the outflow cannula velocity. And so let's look at this. So you see that inflow cannula, and you see how it's very close to the distal septum, and then you go on short. It's anterior instead of in the middle of the left ventricle. And he actually had Doppler patterns that were higher than what we would expect. I would call this one with more confidence, inflow cannula malposition. And now there's a spectrum, right? And let's look at this. So this on peristernal, that looks more posterior just by peristernal.
This is bad.
Yeah, this is bad. In fact, look at that posterior leaflet. That's not very happy. And then look at your short axis. Instead of being anterior, remember we wanted the middle of the left ventricle. It's posterior. And then look at your forapical just by 2D. You see that metallic artifact kind of coming out of the this is overt. So this is, I give you the extreme. This is overt malposition.
Now it's interesting that it doesn't seem coming from the apex. So I just wonder if the surgeon had to go.
So sometimes they change the direction specifically with these pericardial pumps in terms of trying to be more inferior, and they're doing what they can. But for a HeartMate 2, this is just malposition. And I can't explain what they use the LAD. They have some landmarks that they go by surgically. So, but for the most part, it's a non-issue. And let me go back to the.
They don't use any echo guidance for an implant?
No, I don't know, because I don't think I don't think the TE consistency of true apex has been as reliable to help them. I think it's good for the base of the heart. I think they can troubleshoot valves. Yeah. So, but they have not. There's some discussion on, and we do pre-LVAD CTs to try to give them some landmarks, and then we have pre-op echoes based on transthoracic. But no, I mean, I'm very interested in your take on possibilities with real-time echo at the apex to understand positioning and needle guidance and other things. But no one's. They use TEE to confirm position thereafter, and when they close the chest, there can be some movement, but it's too late. They've already cored the apical core. So we talked about some of the surveillance standards, and then just to wrap this up, and I'm going to show you some hemodynamic data related to what we expect. So in addition to standard echo, if we can record the apical inflow peak systolic and diastolic velocity, that'd be great. Comment on inflow cannula positioning as best one. Describe it if you can't commit on whether it's position or not. And then the aortic valve opening. I think those are the items that I think we can enhance here. And then committing on elevated filling pressure or not in the setting of a continuous flow pump and its effect on the mitral valve, the flow coming through the mitral valve. I'll tell you how what we've derived here to guide you, but it's not the traditional ASE recommended algorithm. So let me go, and this is just the Mayo experience with systolic and diastolic velocities, tracking its association with hemolysis and resolution of hemolysis, and the most sensitive technique actually by imaging to help track. So this is just one piece of data to suggest why it's important. I'm not going to spend a lot of time on aortic insufficiency. I would quantitate it as you routinely would do based on vena contracta. I like left ventricular outflow tract width versus the jet width versus outflow tract width myself. But remember, the nuance here is that this is typically, the aortic valve is persistently closed, and it's in systole and diastole, so one can argue the volume going into the left ventricle compared to traditional AI assessments in a non-LVAD patient. And so there's been no gold standard in terms of trying to correlate what imaging parameters most accurate compared to true volumes assessments or modeling assessments. I think if you have someone that has aortic valve opening and unlikely to be severe AI, let me just say it like that. I haven't seen a scenario with aortic valve opening and severe AI, unless it was pre-existing. Acute de novo acquired LVAD insufficiency is usually continuous and associated with valve fusion. So this is what I want to talk about. So the hemodynamics, and I'm not going to go over how we traditionally evaluate hemodynamics in a heart failure patient. I think our lab and you guys have been well exposed to this. But this is the algorithm that we use. We looked at a little over 50 patients in the cath lab with concomitant echo, and our questions were what parameters are associated with partial LV unloading defined by wedge more than 15 versus not. And so we did a derivation cohort, and then we did a validation of 10, 11 patients. And what held up, similar to the ASE document, is mitral valve EA, but looking at estimated right atrial pressure, looking at LA volume index, and NEE prime. And I'm not giving you the details of the sensitivity specificity of each individual parameter, but this is what I look at when in addition to LV size. Remember I told you post-op LV size relative to pre-LVAD. But if I don't have readily available that pre-LVAD measure, and I'm looking at, which we should because they all come from here, I look at these parameters to determine whether estimated LV filling pressure is up or not. And so there's some subtle differences, and I think this exemplifies it. Someone with a HeartMate 2 at 9,000.
And it's interesting that you have the left atrium there, which would be, I think, in this situation, very nonspecific.
So it held up in our data. Usually you get LA reverse remodeling with chronic LA unloading, and no one's really looked at to what degree should you expect to see to have complete LV unloading. And there are scenarios in AFib and other where it can be nonspecific. So that's why it's not a parameter in and of itself. But to be honest with you, it held up more than deacceleration time and some of the other traditional parameters.
Jerry, if LAP is increased by catheter or by our Doppler estimate, is that in itself a finding of the pump not working as well as it should? Because if you theoretically unload, those LAP should be nice.
So in the old days, I would say it would be because we used pusher plate pumps and they were volume displacement. In other words, they were robust. But the nuance now is I can set the pump speed, and no pump speed works for every patient. And occult hypertension is very challenging. So if you have excessive afterload, especially with a pump speed that's relatively conservative in terms of being lower, we see elevated wedge all the time. And so it's not that the pump's not working, it's that the user and the patient interface in terms of understanding hypertension is not working.
So then you would try increasing flow?
Yes. So what we do is we ramp up the pumps. We first make sure blood pressure is stable, and the fellows know this well in the number of dyspnea patients that come in on an LVAD support. The challenge is they have so many comorbidities, and it can be hard. That's why we use echo. We used to cath everybody. But when we derived this algorithm, it's been very useful to curb the need for right heart cath. But to answer your question, we augment pump speed. I used to do it in the cath lab to understand what pump speed associated with what wedge reduction, and to ensure that we're not over unloading based on suction events. But I've transitioned. We're doing a lot less cath, and we're basing it on echo and clinical exam. So this was the original paper, and again, I'm going to skip the details in terms of its accuracy. I can tell you it's accurate. I'm biased, right? We wrote the paper. Now, the aortic valve, there still remains controversy in the field related to aortic valve opening. It is in the guidelines, largely based on opinion, to maintain some aortic valve opening. The best case scenario is you achieve heart failure remission, their wedge normalizes, and you have at least intermittent aortic valve opening. That's nice. Yeah, at least partial. Now, so that's our challenge. We tried to achieve that balance, and it takes assessment, reassess, and things change when the patient goes home in terms of diet and afterload. So let's jump into the speed optimization, and let me jump in here. This is what we're doing. Before, and I inherited it from Fraser a decade ago. He just...
You may have said this and I missed it, but I did. So what's the magic threshold of velocity that you get concerned? When they record a velocity through the LVAD cannula.
Oh, when it's over 2 meters per second.
So 2 is your magic.
Yeah, so this, is it called a Reynolds number?
The angle, of course, can affect this.
So angle can affect it. Patient LV cavity, right? It can affect it. And then certainly the position influencing the angle. So afterload, preload, position, and pump speed are the parameters that affect that velocity. Yeah.
In our reports, my personal bias is if I see an elevated velocity, like 2 meters, I call it.
Yeah.
But the absence of an elevated velocity, I don't necessarily say normal because I don't know the angulation.
Just give me the velocity.
And you want the big one.
Yeah.
Peak.
Ideally, now, peak's more prime time for clinical use in terms of how I'm going to use it. But I like the peak diastolic. But give me the velocity and you don't have to worry about calling it. You can call it high if it's above 2. But I'm going to put it in context to everything. Clinical.
What's normal diastolic?
That's a very good question. I don't know.
But then
It's low.
In obstruction, what happens? Velocity goes down.
Yeah, so let me show you. So in IVH here equals hemolysis. We think there's a clot in the rotor. So diastolic velocity goes down. And so the systolic to diastolic ratio goes up. And so we're following the ratio, but with obstructive physiology, diastolic, and that makes sense, right, in terms of the pump's contribution to flow. That should be continuous. But it's subtle. I mean, right, you look at these velocities. An average, I would think, would be around 40, 50 centimeters per second, right, with decrements probably under 10. But we don't have a cutoff. This is not as widely used in terms of the diastolic.
So does systolic go up also in obstruction?
No.
No. So diastolic goes
Down. Yes.
So what does a high systolic mean?
It could mean inflow cannula malposition. It can mean we over-diurese the patient and the LV cavity is just too close proximity to the inflow cannula, and it's a workable inflow, as probably the two most common. So I don't want to take all of Su Ming's time. So optimization, real quick. Historically, we were doing 8,000, 9,000, 10,000, 11,000 for the HeartMate 2. Those are broad sweep speeds. To create that balance of understanding unloading, trying to minimize future adverse events, and create a scenario of intermittent aortic valve opening, there's more subtle sweep speeds that we've gone to. So if you're on a baseline of 8,000 revolutions per minute, the protocol is we're going 200 RPMs down and no lower than 8,600 because we won't set it below 8,600, and then we do 3 above. And so I think from a echo technician standpoint, whether it's 8 versus 9, it's 4 subsequent speed changes, and then it's very limited views, not the full echo again at every speed change. It's looking at LV size, MR severity, and aortic valve opening, to be honest with you. So it's a peristernal, a long and short, at these speed changes. I think that's going to create happiness for a lot of people. right. Now, right. And, yeah, that's the biggest challenge, right? When you have 2 hours of one echo on one patient. And so this is an example. This was inflow cannula malposition, high-grade MR, clinical heart failure, and at high pump speed settings, less MR, LV's a little smaller, and so we leave the patient at a higher pump speed. I'm giving you broad pump speed changes to demonstrate. But it doesn't have to be inflow cannula malposition. This guy had a perfect inflow cannula. You see the inflow cannula artifact of the peristernal long at the apex? But he had high-grade MR. I'm showing you a snapshot. Certainly you do the full integrity. And his LV was big, and I had to crank that sucker up. His inflow cannula was appropriately positioned, certainly making sure. So some people need a higher pump speed. And we think they're obesity and bigger LVs to begin with. And so the heart failure optimization, but this is what we want to avoid. And this, again, extreme example. At higher pump speeds, that LV is sucking down. That's VT, that sucks against, that's pre-syncope, that's syncope. I have a patient anticoagulated, they fall and hit their head. That's a major challenge. So I'm looking at the balance. I'm looking at the balance. And some patients will come in with VT and or pre-syncope, and we see their echo. We're immediately going to reduce the pump speed. Heart failure can be fairly forgiving, right? We'll reduce the pump speed. We'll allow for a little bit of heart failure to resurface, give fluids, and readjust. So this is the concern, LVAD suction event. And so on heart failure optimization reports, it's the baseline echo, the things I mentioned related to inflow, the cannula velocities, aortic valve opening assessment, the intracardiac assessment by the algorithm we provide, and the LV size and aortic valve opening and MR. Those three parameters at the pump speed changes. If you could tell me that on the report, that's perfect. Now, to be honest, you guys know, we go look. But this would be an ideal algorithm to follow and monitor. In fact, that's my proposal here today, is to have 3 algorithms printed in the echo lab, and you guys say, okay, the fellows, this patient's getting this echo for this reason, this is the expected report, and then I monitor that as being done. All right. And so let's go to the third one, is pump malfunction. Now, the Columbia guys used an algorithm at multiple pump speed, 8, 9, 10, 11, 12. And the concept is, if the LVAD's working fine, that LV should decrease in size. And the aortic valve, for everybody, independent of LV contractility, should close. And so they proposed doing spreadsheets and slopes. It's very complicated. And so what we did is we said, well, let's just look at high speed and low speed and look at LV size. We did the full breadth of trying to understand what echo surrogates are associated with normal pump versus pump malfunction. And those that we knew had pump malfunction in the setting of clinical hemolysis that required an exchange. So they had, in fact, these patients had clinical heart failure. And what we were able to delineate is that it was those 4 parameters: LV size, aortic valve opening status, the other 2 related to right-sided estimates of flow, and mitral valve deacceleration time. So this is an example. This guy has underlying reasonable LV contractility, and you ramp up his pump speed, and as you can tell by looking at the 2D aortic valve opening, at 9 still opening, but at 11, look at 11. And that's true for 90+% of our patients with a normal functioning LVAD, is that aortic valve will close. Now, that's compared to this guy, whom he was set in and around 9, and we crank it up to 11, look at his aortic valve. Nothing's happening. The pump's not working. Now, one can argue, just do a physical exam, check a pulse, crank it up. We do that. But this provides, in my mind, confirmation that you have something's wrong with the pump. And it's our job to figure it out. You don't need M mode. You can look at 2D, but I think M mode is very helpful.
So the settings of the pump doesn't tell you that flow increases when you increase the RPM?
So the flow estimate is based on power consumption, and its accuracy related to true flow is modest at best. Yeah, so there's only one pump in research based on a flow probe with accurate flow. And so that's a push to improve things. But yeah, no, so you can imagine, we're sitting here. So what we do, the correlate to pump malfunction and hemolysis, and power goes up. And so flow is artificially elevated. But it's lower, but it's artificially elevated. So we use echo. So this is the rule, the algorithm we follow. So this is just an example of a normal pump based on LV size, aortic valve opening. Mitral valve deacceleration, if you can measure it at high and low, that'd be great, versus it not changing, these 3 parameters.
What happens with RV function with the changes in setting? At times we see if the LV is really sucked down.
Yeah. So typically RA pressure, nothing changes, estimated RA pressure or measured. If you unload the LV too much and pull the interventricular septum over, you reduce efficiency of the RV and you worsen tricuspid regurg. So you may bring out worsening RV failure at relatively high pump speeds. And so we're looking at the interventricular position LV, RV, which way it's bowing. And in fact, in the report, I didn't put it, and I got to put it. You want to comment on what direction the interventricular septum is going, midline, to the left, or to the right? And so this is these are the hard numbers we're looking at in terms of cutoffs, pump malfunction, yes, no. But to be honest with you, you just describing it in terms of the LV size difference between the high and low. So for a HeartMate 2, rule out pump malfunction protocol, it's baseline, then it's limited views at 8 and 11. You're reporting the baseline report at the baseline pump speed, and then you're reporting LV size, aortic valve opening, and deceleration time at 8,000 and 11,000. And I should be able to tell if there's pump malfunction or not. And I'm putting a lot of weight on the aortic valve opening. Yeah. So that helps us tremendously.
Come back, I got confused here. So these are the parameters for
So
dysfunction.
yes, these are the 3 echo parameters.
Still opens.
Yes.
Yeah.
Yeah, that's,
The heart fails to get smaller.
yes.
And the deceleration time remains short.
Yes, it does. Yeah. Those three help me. And then, so yeah, this is an example. But to be honest with you, we've tried to make it easier. We cut out the 9 and 10. I just want high and low. So this is the modified pump screen protocol, and this has been adopted actually across the country. The last one, to be honest with you, in the sake of time, I'm going to not go over in detail. The concept is if we're screening for recovery, we don't judge it at the baseline pump speed, and instead of ramping up, we ramp down. We'll go to 8,000, 6,000, and look to see how the LV size is, RV sizes, intracardiac pressures, and severity of mitral regurg. And so there's a program. Now, a lot of what I mentioned, we're proud of this document. It came out in JACE, and it has protocols. It goes over multiple examples, and good for the text, good for those interpreting. So I refer you to that, and it gives you the details of computation. So with that, Sue, man, you want to jump in on CT? I didn't comment on how we're using echo to screen for other complications, intracardiac clot, namely, or to be clearer about positioning. And so Sue Ming's going to go over that part.
Okay, thank you, Jerry. So it's an LVAD talk, but you haven't seen any LVAD picture yet, right? You see a lot of echo, flow, Doppler, but I haven't seen any LVAD. But anyway, I mean, but joking aside, echo is obviously the most important screening test and give you physiological information. But after you screen the patients and you suspect malfunction, I firmly believe, like Jerry mentioned, I think if the patient can undergo a CT, it can provide oftentimes, not every time, some answer to the question why the patient is not doing well, and the surveillance echo is not normal. Obviously, I wish we can get all the patient picture like this in echo, but it's obviously not possible. And I'm going to forgo that. Basically, I'm going to show you some cases that we've done over the several years, the complication of LVAD. Basically, I grouped them into these 4 categories: inflow, cannula, outflow, aortic root clot, and some of the surgical complications not unique to LVAD, but it's important. So most common LVAD we implanted here that we have experience with HeartMate 2. As you can see, is consistent to inflow cannula, conduit cannula, the pump in the middle, and the leads go outside the patient's body. The normal cannula position, I mean, if you look at the literature, there's very few literature in terms of what define a normal cannula position, but one would presume that you want to be aligned exactly to the mitral inflow, so there's no impediment of flow from the LV cavity into the inflow cannula. And the outflow cannula, again, this should be ideal position, straight from the cannula, straight from the pump, all the way up, without about midway between the aortic arch and the aortic root. Again, the position of this anastomosis site is unknown. What's the optimal position? And we are currently studying with some flow modeling, computational flow modeling. And this is the other device, the new device that Jerry mentioned. So you can see it does not have inflow. There is an inflow cannula, but there's no connector So it's I'm sorry, I can't, yeah. So there's no connector between the inflow cannula and the pump, so this thing is right underneath the heart. And that creates sometimes issues. We have limited experience with this new pump. As you can see, this is the pump, this is the inflow cannula, inserts right straight into the apex. For unknown reason, we have a couple cases. This patient had beautiful picture, minimal artifact, and this patient have a lot of artifact. It's the same pump. So hopefully with more experience, we'll gain insight into why caused this artifact. And this is what it looks like in thickening the data sets, as you can see. Obviously, the design is very different. Therefore, the position of the outflow cannula, the pump, in the position of pump instead of subdiaphragmatic, this is infracardiac, I presume. So that kind of altered our experience in terms of the relationship of the outflow cannula. You can imagine the trajectory is slightly different. As you can see here, this outflow cannula has to go across entirely from the heart and go all around to the lateral side of the ascending aorta. In this case, even more dramatic. I think Matthias has to put in the descending aorta.
So that was the original proposal, and what was with the jargon about over a decade ago. And that configuration was associated with overt aortic stasis and clot. The outflow wasn't washing out the roof. Horrible thromboembolic prevalence and incidence. So we will only go descending if there's a portion of the aorta or something we have to avoid, minimize surgery. So that is the minority, vast minority of cases versus the goal.
But still, even if you put in the ascending aorta, you can see the length of the outflow cannula is much longer. So we don't know what's the long-term consequence of that. So just show you some other. Okay, so this is a case of patient with suction event and ventricular tachycardia. This is some of the cases we published in JACC Imaging a couple of years ago. As you can see, very turbulent flow in the color Doppler, very high velocity. And this is definitely a malposition. I mean, you can see the cannula is stuck into the septum. And this is actually another case with suspected suction event, but in this case, the flow wasn't that elevated. It could be due to the angle of imaging, echo Doppler interrogation.
The absolute velocities were way down, so you had that pattern.
There we go. There we go.
But we couldn't see the inflow cannula after.
Right.
Yeah, and also the issue here is, so where does the issue reside? Which part of the pump is a problem? And you can see this is the older version of the pump, a different type of LVAD. You can see the cannula is stuck in the apical anterior wall. So essentially, and the other patient that we scanned also, instead of suction event, I think he presented with recurrent tachycardia, ventricular tachycardia with different position. And well, in the CT scanner, you can see it in doing a non-contrast scan, he was in sinus rhythm. And once he hold his breath with changing of the breathing pattern, you can see he went into ventricular tachycardia. And I think that's because of direct irritation of the cannula to the myocardium. I think he got appropriate shock and then change of transplant. Okay, in this case that Jerry already mentioned, you can see the inflow cannula tip is barely 2 centimeters from mitral valve tip, and definitely because of the mid-posterior wall insertion side, I'm sure he altered the mitral valve apparatus, causing worsen MR after the LVAD insertion. And an outflow cannula now is probably the most difficult image via echo because the variation in terms of location of the anastomosis and the trajectory of the outflow cannula. As you can see, this is just quite common because when the chest is open, the surgeon try to put it in the ascending aorta as best as they can. Once you close the chest, the space and anatomy change so that things could move. There's probably it's quite common. We see a little mild kinking, but again, we've seen a couple cases of really severe kinking with this patient. I think he presented with heart failure syndrome and low flow and high power spikes. Again, without CT imaging, it would be very difficult to decide where the problem was. Again, this is fairly uncommon. And this is still remain a mystery to me at this stage. I think this patient didn't do very well. He presented with some automental status, and eventually, I think he went to hospice. You know, he obviously has chronic renal failure. He was CKD stage 3 or 4, so we didn't give contrast. We gave non-contrast. We did a non-contrast study. And you can see he has multiple pocket of air. I don't know, could be infections, but so there's something that you can even see it without contrast. So even in the presence of chronic or acute renal failure, sometime non-contrast study could provide some, occasionally some answer. This is a very interesting case. Patient with recurrent bleeding. I'm sure you know who it is, Jerry, from his driveline site. Keep coming back. The ER with bleeding from the driveline site, and we did a CT, and you can see there is a little pocket here in the insertion site between the outflow cannula and the ascending aorta. This is a 3D rendering of the pseudo and yeah, right here. So this is the outflow cannula. This is ascending aorta, and this shouldn't be here. Okay, so a little pseudo aneurysm on the stomatis side. Bismuth took him to the cath lab multiple times, put the occluder device, and obviously after he put the occluder device, he can't see anything anymore. I don't know whatever happened to him. Did he get better?
Yeah, we thought it was these patients on continuous flow pumps are predisposed to myocardial formation in the setting of aneurysms. We've seen in the brain, we have bacteremia, aneurysm formation. Something about endothelial dysfunction, partial full pressure. So he, unfortunately, rare case, developed an aneurysm at the anastomosis that became super infected.
Mm-hmm.
And 2 weeks later, he had a fistulous tract. So he just had revert bleeding.
Anyway, so this is again very dramatic case, very rare. Fortunately, you can see complete instead of I guess micro or small clot inside the pump. This is overt clotting of the outflow and inflow cannula. This is obviously patient do very poorly, and this is obviously getting on low with increased suctions, and you can see the clot both in the outflow tract, outflow cannula.
So if we see hemolysis with pump malfunction by echo, we'll get a CAT scan for surgical planning and how to deal with the outflow cannula in terms of where they're going to clamp and in terms of taking the pump out. Because if there's significant outflow cannula clot, they're going to be very proximal.
Exactly.
And evacuate that, maybe even re-anastomose. So we'll follow up every hemolysis, pump malfunction patient as long as the creatinine's okay with the CT contact.
The amazing thing to me is just thinking back about the position of the cannula in the ventricle. I mean, you have no anchor. You could position it wherever it is, but ultimately when you start moving things around, that cannula is going to move. You have no anchor. At least it would move in the 360 degree, not necessarily slide.
So there is an anchoring around the inflow cap. So they anchor it, like the apical cord, and there's an anchoring device, and they do a suturing. It's all around. So, yeah, I just want the fellows to make that sucker spin. So it's anchored, but yes, it's been cleared by x-ray and serial echocardiography. In some CT limited data, the inflow cannula position changes. That's accepted.
Yeah, because patient body size changes, the heart size changes. Anyway, this is again another complication we rarely seen. I think we have 5 or 6 cases that we know documented of a thrombus, aortic root clot. This patient presented with left sinus of valsalva thrombosis with intensive anticoagulation. The clot becomes smaller. This is another patient with multiple clots.
So in this scenario, so we have a stroke prevalence is around 10-12% per year, not negligible.
12% per year.
10-12% per year. Yeah. And so if we have a non-hemorrhagic thromboembolic stroke, we have to go through that differential, and aortic root clot is part of that. So we do CT. It's typically with aortic valve not open, but it guides us in that we're not going to let it open. Right? We're going to purposely keep the pump speed on the low side, even if they have a little bit of clinical on the side become part of that diagnostic workup.
Yeah, one thing we haven't looked at carefully is also, clot in the left atrial appendage, because a lot of these patients, I'm sure, have atrial fibrillation. So that's the other thing that I think is worth looking into.
Has there been any reported thrombosis of the sinuses when you have partial or intermittent OV?
I haven't seen it.
We're currently, we have the data, so we actually collect it. Mawashi is not here, but we have that information.
You should look at that at least and see if there is intermittent, at least it will give you that safety.
That's what, yeah, so we think that, and would hypothesize that with intermittent level, but it's influenced by that outflow cannula position, right? So those are the two things that influencing flow to the group. The outflow cannula's position, direction, your pump speed setting, they always got pump.
And this is despite anticoagulation?
Yeah.
Yes.
Now, some people are more predisposed to hypercoagulable state, but yeah, this is despite an INR goal between 2 to 1.
Anyway, so this is a lady who had this multiple clot, and 6 months later come back, and those clots are gone. But I know even keeping it close. So this is obviously a surgical complication. A patient with BIVAD actually with hemodynamic collapse, traumatic cases of acute tamponade, and
So that tamponade, I like to spend some time. So that's an early result. I didn't even touch in on that. Tamponade, when you're on an LVAD, can be very challenging. So we look at.
That's not in LV collapse.
Yeah.
Yeah.
So what we look at, they usually have low flow alarms, hypotension. But echoes first line, just we'll do it quickly. But if we, be honest with you, if we just see large fluid or clot in that scenario, we're done. Yeah, we're done. So
I would agree.
So we do that just quickly, that hour. But in those with more complex, perhaps anatomy, we'll pursue CT. But you typically should be able to see it by echo.
Yeah, no, this case obviously it was clinically suspected, but we can see how small, the RV and LVR. Added to that was interesting. There's a BIVAC case which we don't put that many, and there's also some kinking of the outflow cannula. Infection, fortunately, is not that common. I don't have too much experience, but essentially, CT is recommended as class 1 indication for the International Society of Lung Transplantation that other imaging modality cannot reveal the cause of the pump malfunction. And again, there's obviously a lot of challenges in terms of this artifact that we talk about. There's some, I saw some presentation in terms of using different computer algorithms to get rid of metal artifact. But really the ultimate goal is to look at, to be able to do this type of imaging. You can see through the pump, ideally, and at least to detect a small clot. That'll be, I think, very useful. I'm trying to talk to the manufacturer in terms of, getting us the algorithm and the software for us to do that. And not only that, I think this, CT, now we have so many patients, and so with excellent follow-up because of Jerry's initiative, and it represents a huge opportunity for research, especially from multi-modality standpoint. And I think we have some work on the pipeline. And too bad that the Echo Tech has left. One of the things that I was talking to Kelly was, Kara was also, we do all this routine scanning. I don't know how long it takes for them to scan an LVAD patient. I guess it depends on how good a tech is and how patient it is. But if you have a patient who already have a CT, it's very easy for us to tell them exactly where the cannula is. So instead of spending time fishing for the location, I wonder, if it's worth if any Echo Tech is interested in doing a study comparing, knowing the information in CT and not knowing it in terms of time you save in acquiring the study and maybe acquiring the proper information. This would be an interesting thing to do.
We looked at the burden of what it was for acquisitions and time, all that's charted, you go back and look. It's twofold for a heart failure patient. Everyone else out there. So you have, but we do 60 LVADs a year, but at any one point there's several to
very tough. And the success of getting the information you need, especially for alpha cannula, I mean,
You get a lot with that.
yeah. Anyway, thank you.